Well,
Okay.
thank you. Good afternoon, everyone. I'm sorry I couldn't be there in person. I too am traveling. I'm actually in Prague at the moment on my way to Europe PCR, but nevertheless, thank you for the kind invitation to join. My role today is to speak to you about transcatheter tricuspid valve replacement as a nice segue from the prior talk on transcatheter edge-to-edge repair of the tricuspid valve. These are my relevant disclosures. So I think it's important to appreciate that there are a number of challenges with respect to the tricuspid valve, and some of these were identified in an earlier talk on imaging and certainly in the last talk on edge-to-edge repair. But some of the challenges we face and hence impact the procedure and also the choice of device or the position and size of the regurgitant jet or jets, as there may be multiple, the number of leaflets, and I've never been so struck by how many quadricuspid tricuspid valves there are until I started working in the tricuspid space. The presence of pacemaker leads, the various shape and size of the tricuspid annulus, the variable and complex leaflet anatomy, particularly when they're tethered leaflets, especially the septal leaflet, which can be quite difficult to capture. And then, of course, the proximity of the conduction system as well as the coronary arteries. And I think the etiology of the tricuspid regurgitation is also important, particularly when it comes to selecting devices. At least in the United States, we now have commercial approval for the Abbott tricuspid clip. The CLASP TR of the Pascal device, CLASP TR trial is still ongoing. And then, of course, we now have commercial approval of the Evoque replacement valve. And so there are some choices, and the choices are only going to increase. So it's important to understand the etiology, which might help determine which device is more suitable for which patient. For example, patients whose annulus is far too large for an edge-to-edge repair may be better suited to a transcatheter replacement. Similarly, patients who have multiple jets or complex leaflet pathology, which would preclude them from having edge-to-edge repair, may be better served with a replacement. And then conversely, there are a number of patient and anatomical factors which we'll get into, which may preclude a replacement device. We're all familiar with the newly proposed classification system. As I mentioned, I think this is something we're seeing as we look at more and more of these echoes. I think this is more important for the edge-to-edge repair, particularly these quadricuspid valves that have divisions or scallops of the leaflets. But I think even it's just as important for the replacement devices where you've got multiple jets involving multiple leaflets that may be more complex and challenging for edge-to-edge repair. The idea of this expanded classification system of severity is quite interesting, and based on some earlier data that showed us that even when you had a reduction in TR and an improvement in clinical symptoms, the overall TR grade based on current conventional echo criteria would still say that the TR was severe. So you were taking patients from severe to severe with no delta on their echo report, but yet there were clearly improvements in RV volume, in overall TR, and importantly, how patients were feeling. And so that was really the platform for this proposal to introduce the gradings of massive and torrential. Again, I think seeing a reduction from torrential to massive or severe is something we see more on the edge-to-edge space. When we're dealing in the replacement space, it's a much more drastic amelioration, if not complete mitigation of the tricuspid regurgitation. We heard a great talk on imaging, and I think the role of imaging in the tricuspid valve cannot be understated, particularly CT in the pre-planning phase. Of course, transesophageal echo still remains the gold standard for intraprocedural imaging, although we have been using ancillary intracardiac echo, not so much to guide the positioning and trajectory of the device, because that can trick you, but more for ensuring leaflet capture, particularly when there's shadowing of the device under TEE. So I'm going to speak about two valves, predominantly focusing on the Evoque valve. I'm not going to speak so much about valve and valve and valve and ring. I think we're all familiar with the expansion and use of the aortic devices in the tricuspid space, but really about the dedicated devices for the tricuspid valve replacement. So this is the Intrepid valve. Currently, it's a 35 French system and it's EFS. There is a newly designed and developed 29 French system that we hope to see in the near future. This is a very similar device to the mitral Intrepid device, which is part of the Apollo trial. So you can see this flexible brim there, which is within it is housed a valve that's 26 millimeters across. So it's all one contiguous device, and it's deployed in a top-down fashion. So the capsule enters the right ventricle, and then the valve is unsheathed. You can see the brim unsheathing here. The brim sits on the floor of the RA, and then the valve is deployed intraannular. And you can see those small fixation tines there, which adhere to the tricuspid annulus. For those that have had experience with this device in the mitral position, it's a very elegant, very seamless, straightforward device. And so that trial is currently underway. Some of the elements of this study, so classic study design, heart team assessment. This is for symptomatic severe TR, so not moderate, but severe and worse. They obviously have to have adequate transfemoral access. But I'm going to focus here on the EVOQUE device just because it's been commercially approved and we have the most experience with it. So this is a very interesting valve design, has these atraumatic anchors. So converse to the Intrepid valve, which deploys in a atrial to ventricular fashion. This is more from a ventricular to atrial fashion. This got this conforming frame, which is designed to achieve this retention force of the leaflets. And the mode of retention of this device is twofold. One is the radial strength that's outwards towards the tricuspid annulus, and the other is the entrapment of the native leaflets within those anchors, and that ensures that the valve stays in place. There are multiple sizes that offer a broad range of treatment across pathologies. The approval is for every size up to 52 millimeters. The 56 millimeter device, which is the largest size, is currently not commercially approved. It's still only available through a continued access scheme, simply because the 56 millimeter device was introduced much later in the study. And despite the 56 millimeter device, we're still seeing a not insignificant proportion of patients who are excluded because they have an annulus that's even larger than what would be treatable by the 56 millimeter device. So this is how the procedure works. It's a transfemoral transvenous access, 28 French outer diamond delivery system, and there's 3 planes of movement of the device. There's a primary and secondary curvature, which allows you to maintain coaxiality. It's delivered over an extra small Safari stiff wire, pre-curved wire that sits in the right ventricular apex. And then the valve is slowly unsheathed in stages under very careful guidance with both fluoroscopy, but mainly transesophageal echocardiography, until the valve is fully deployed there. You can see with the ventricular aspect where the leaflets are housed within the device, and then the atrial aspect. So let's go into some of the data. This was quite impactful earlier this year. So this is the TRISCEND-2 study, building off the TRISCEND-1 study, which was for moderate and severe tricuspid regurgitation. This was severe. And so this is a randomized study. And you can see here the primary endpoint of safety, effectiveness, and then this hierarchical composite of additional outcomes at 1 year. And so this idea of a breakthrough pathway cohort is what led to this early FDA approval. And so the safety endpoint was met at 30 days, and a 6-month effectiveness endpoint, which was based on the TR grade reduction to less than or equal to moderate, and then a composite of an improvement in their KCCQ score, NYHA class, and then 6-minute walk distance. Meeting both those primary endpoints is what led to the FDA approval. There was also some data from the full cohort in terms of what 1-year data was available that was also presented. But the full cohort 1-year data is going to be presented at TCT later this year. So these were some of the patient characteristics. You can see there the medical therapy group versus the intervention group, very similar across both patient characteristics, comorbidities, and phenotypes. The degree of tricuspid regurgitation, you can see here a significant proportion of these patients were graded as having massive or torrential TR. So there certainly was a tendency in this study to put patients in compared to, say, some of the patients in the edge-to-edge repair with more significant degrees of TR. All of these procedures were done under general anesthesia, very successful implant rate. The procedural time was actually quite reasonable considering the learning curve with this device. So, on average under 2 hours. And the device time, which is from when the device goes into the device delivery system coming out, was just over an hour with about 30 minutes spent on fluoroscopy. These patients do tend to stay in hospital a little longer. I think we're learning still how to manage these patients and how critical it is to look after them in the peri and post-operative period. It is the idea RVP coupling or uncoupling, impact change in both patients in terms of their RV function. So keeping an eye on their volume status as well as their conduction afterwards is very important, part of why we keep these patients in hospital for a few extra days. So just going through the safety endpoints, this is at 30 days, the composite major adverse events. Mortality was quite low, no strokes, there was no need for dialysis. Bleeding was really the biggest driver. These patients do need to be on at least 6 months of anticoagulation. And so the bleeding rates we're seeing come down now, but I think probably related to access site bleeding because of the large venous sheath, and the fact that either a lot of these patients are already on anticoagulation for atrial fibrillation and the remainder needing to be started on anticoagulation. So that's certainly a consideration for patients who may not be appropriate for the Evoke device, are those that cannot tolerate any anticoagulation. Arrhythmias requiring pacing, another, I think, Achilles heel of the transcatheter replacement. Hopefully we see these numbers come down. We've been very aggressive with the degree of oversizing that we use just to ensure that there's very little PVL and, of course, no migration of these devices. But I think similar to what we saw in TAVR, we hope that these rates will come down as we get a better understanding of sizing these devices and therefore having less oversizing without trading out rates of PVL and embolization. This is just a breakdown of the bleeding events here. You can see none of those bleeding events were fatal. And most of them were related to the device or the procedure, and as I mentioned before, mostly due to the access site. So what about the effectiveness? And that was, as I mentioned, moderate or less TR. So you can see here there was quite a drastic reduction, as one would expect, with replacing the valve versus an edge-to-edge repair. So all of these patients basically had down to mild, moderate, none or trace TR. And that was, a sustained result out to 6 months, and obviously a drastic difference compared to medical therapy alone. In terms of the composite of how these patients felt in terms of their scores, so you can see here, again, this is a win ratio similar to what was presented in Triluminate. So a significant improvement in their KCCQ scores demonstrated by a delta of more than 10. The NYHA had to improve by at least one class to deem an improvement. You can see there was a 20% improvement in the Evoke plus medical therapy versus just 2% in the medical therapy alone. I think importantly, a lot of the patients that we saw who were referred for this therapy were those in whom the medical therapy had clearly failed by whichever metrics you judge that. And then there was a small proportion of patients in whom medical therapy was not tolerated, either due to renal dysfunction, hypotension, or some sort of adverse reaction to mostly their improvement in 6-minute walk distance was not significant between the two groups, but overall, clearly a significant improvement with the cumulative improvements in KCCQ, NYHA, and 6-minute walk distance with Evoke plus medical therapy compared to the medical therapy alone. And again, this is just showing the delta between those two, and you can see there the NYHA class driving most of that difference, as did the KCCQ score, but not a big difference on the 6-minute walk. In terms of changes in morphology of the right ventricle and IVC, there were changes in the right ventricular end diastolic diameter out at 6 months with the Evoke group, so already some signs of positive remodeling. As we know, the right ventricle is quite responsive to changes in preload. So when you take away a lot of that, there's a reduction in preload, you expect the ventricular volumes to decrease, unless, of course, the right ventricular dysfunction is significant. But importantly, patients who had worse than moderate RV dysfunction were excluded from this study. The right ventricular fractional area change, you can see there was a improvement based on the Evoke device, and also longitudinal function. And TAPSE is obviously a surrogate for the RV function and an important component of when we're assessing for RV coupling. The relationship between the right ventricular function and TAPSE is a surrogate of that, as well as PA coupling. And what we've seen is that the patients who have preserved RV-PA coupling, that is the right ventricle's ability to respond to changes in afterload, mainly derived from pulmonary artery pressure, is a marker of adverse outcomes. So when you've got preserved RV-PA coupling, your clinical outcomes are good, versus if you have uncoupling at baseline, that usually reflects an inability of that RV to respond to those changes in afterload that we're going to see once you take away that pop-off of the TR. Pulmonary artery systolic pressure, not a meaningful clinical reduction, but nevertheless trending in the right direction. And then importantly, the gradients were elevated slightly, as one might expect with this device, but certainly not to a level which is of any clinical significance. Remembering, again, these patients are placed on at least 6 months of anticoagulation. Obviously, we will need long-term follow-up to ascertain whether there's any issues with leaflet thickening and thrombosis, as we've seen on the left side of the heart. Stroke volume improved. Of course, there's now more forward flow. And in turn, there was no reduction in the left ventricular alpha tract cardiac output overall. That was maintained. There was a slight increase, but no significant difference between the medical therapy and the Evoke groups. So this is the data from the full cohort. Not all of the patients were available. Roughly 300 patients data was available for this. This is the 1-year endpoint of mortality, the need for RVAD implant or transplant, the need for surgery or reintervention of the tricuspid valve, heart failure hospitalization, and then the other metrics based on patient scores. And so these are what was the data available. So 250 patients or nearly 250 patients available. By the time visits were completed, 220 patients. And this is just showing, again, a significant improvement across all of those hierarchical endpoints, starting, of course, with all-cause mortality for the patients in whom the follow-up was available. But again, the caveat being this is not the whole group. There's a favorable trend towards mortality, but I think it's definitely too big a statement to make that there is a mortality benefit here, but at least the numbers are trending in the right direction. The rates of heart failure hospitalization, slightly less. And then, of course, the need for tricuspid intervention. We didn't see a significant increase there with the need for intervention. This, I think, is distinct from what we see in edge-to-edge repair, where not infrequently these patients need to come back either because of significant residual TR or worsening TR and the need for additional devices. We're not seeing that. Once the index procedure goes well here, their TR is gone, and so you would not expect there to be a need for a reintervention or surgery. The early results that we saw at 6 months in terms of the improvement in KCCQ, 6-minute walk distance, and NYHA are certainly sustained at 1 year and arguably a more magnified effect of those early changes we saw at 6 months. So in conclusion, based on the results of this led to FDA approval. The safety and co-primary effectiveness endpoints of the breakthrough pathway were certainly met with an acceptable safety profile, although I still think there's work to be done in terms of reducing bleeding and the rates of pacemaker. Clearly, it's an improvement over medical therapy alone, but I think we're still learning a lot about which patients to treat and what is too early and what is too late. I think, like any technology, goes through these cycles, and I think that we're out of the trough of disillusionment when it comes to the tricuspid valve, and I think we're entering the slope of enlightenment, but we still have a lot to learn before we enter the plateau of productivity. And so very excited to see what the 1-year data from TRISCEND is at TCT, and we obviously didn't have the scope to talk about some of the other therapies looking at other parts of the tricuspid valve, such as annuloplasty. But I'll end there and I'm very happy to take any questions. Thank you. Dr. Panos, I think you're muted.
Dr. Sharma, can you hear us?
I can hear you, but I think,
yes.
There we go.
Okay, yeah. Thank you for those amazing news. And I would like to ask to Dr. Ziakas in Athens to comment on what he is thinking or his experience, already experienced on the Evoke valve in Thessaloniki.
There's very little experience in Thessaloniki with this valve, but I think the presentation was great. And everybody would like to ask one question to Dr. Sharma, as he's, I think, a guru in this topic. So I would like to ask Dr. Sharma to do a prediction in 5 years' time, as the technology in the valve is evolving. How many patients will go for repair? How many patients will go for valve replacement?
It's a great question. I think there's a couple of factors which will determine that. I think, as I mentioned, anatomy and the ability to deliver the valve is a big predictor. Of course, we all love the idea of getting rid of all of the TR. That makes the most sense. If we had a choice between reducing versus completely mitigating, I think we would all choose that. But we have to be careful because, as I mentioned, I didn't have time to delve into it. This idea of RV-PA coupling is something we're getting a better understanding of. And Becky Hahn has done a lot of work on trying to look at echo parameters to predict which patients will fare well. We know that replacement has a bigger impact on RV dysfunction, particularly valves which are oversized, the impact on the basal RV in terms of reducing function that take a bit of a hit. And that sudden change in preload and the corresponding changes in afterload, if you have an elevated pulmonary artery pressure and the RV, there's a threshold at which the RV can no longer compensate. And so in those patients, perhaps it doesn't make sense to replace their valve, and perhaps an edge-to-edge repair with a reduction is a more appropriate solution. I think the ability to take long-term anticoagulants is important in replacement. The bleeding rates are not insignificant. So I think that while the gestalt would be to replace all the valves, get rid of all the TR, I think the anatomy, and we didn't go into the right ventricular space, the ability to gain height, these devices are quite large, will really dictate, along with patient comorbidities, including RV function and ability to tolerate anticoagulation, what proportion of patients will go, to which camp. The other thing is that, I think we're all very comfortable with edge-to-edge repair from mitral experience. I think a lot of people were underwhelmed with the results from Triluminate and argued that, what's so impressive about a win ratio driven by an improvement in KCCQ? The counter argument to that is that if a procedure has the safety profile of edge-to-edge repair and results in a symptomatic improvement for those patients, is that an adequate threshold? And I think that's a reasonable argument. If those patients feel better with a procedure that's safe, timely, doesn't require anticoagulation, then perhaps that is an appropriate bar. So, I can't give a number, but I just think that these are things I'm thinking about in terms of now and in the next 5 years, where patients go in terms of which therapy.
Dr.
Sharma, thank you. Yes, excuse me.
Ro, Mike Reardon, how are you? Very nice talk.
Oh, hey, Mike.
So, Ro, two really interesting things I wanted to ask you about. One was, the mortality curve is very interesting, not surprising. It was a little higher to begin with, more invasive, but it's really coming down. It makes me wonder, how far would this have to go down as far as long-term mortality before you think it'd be reasonable to randomize against clipping? It'd be hard to do it right now, but what kind of results would you want to see at 3 years or 4 years from EVOQUE before you'd say, well, maybe it should randomize and see how they do?
Yeah, I think that's a really good question. And I think we do need longer term data, because I think that the RV remodeling takes a little bit of time. We need to see where these patients settle out. I also think we need to understand whether 6 months of anticoagulation is enough. We've had patients in whom we've stopped their anticoagulation after 6 months, and they develop leaflet thrombosis. So that's an issue. And what's the impact of that going to be on mortality? So I think that we would have to see the mortality rates, the difference rather between the replacement and medical therapy alone come down. I think probably another few percentage points before it makes sense to say, okay, that there's an unanswered question here in edge to edge. I think the other question is, where is there equipoise in terms of the patient phenotype, in terms of anatomy, as well as some of their other comorbidities. I think that's, I think it's going to, if we do that trial, it's going to be important to get that trial design spot on in terms of making sure it's a fair randomization.
Dr. Sharma, I have a question for you. Is there how we can deal with a pre-existing pacemaker lead? Isn't a contraindication or has nothing to do? And the second question would be, yes.
No, go ahead.
And the second question would be is there any application in the rheumatoid tricuspid regurg or the carcinoid regurgitation?
So the first question about the pacemaker leads. The pacemaker leads were certainly not an exclusion for EVOQUE, and they aren't now. I think what's important is that the presence, location, and amount of slack on the pacemaker lead does not preclude the ability to deliver the device. In certain cases, there might be risk of course, fracturing the lead, but more commonly in displacing the lead. And in those patients who are 100% pacemaker dependent, it's important to have an appropriate backup plan. Obviously, you don't want to traverse the new valve and place another regular RV lead. So the options really are a micro leadless pacemaker or coronary sinus lead in that situation. Primary prevention ICD leads, again, are not an exclusion or contraindication, but secondary prevention ICD leads at this stage are understandably. But the other issue is, of course, the shadowing and the issues you get with imaging, in addition to trying to get around the lead in a mechanical fashion as well. Your second question about rheumatic disease or carcinoid, there were some carcinoid cases done early in the EFS experience, and a couple, I think, in compassionate use. I don't recall, I'm not sure, to be honest, about rheumatic disease, but certainly those patient phenotypes were not included in the main study.
Dr. Mack?
Thank you very much.
So, Rahul, great talk. This is the other Mike from Texas, Mike Mack.
Needs no introduction.
So let me be a little bit of a skeptic here for a minute. I think we have two devices that have been approved by breakthrough device designation. One, you could argue, is safe but not effective. The other is effective but not safe. And so if you just look at the triluminate or TEER, you got 50% of patients with moderate or greater residual MR at the end of the procedure. You've got EVOQUE with a 27% major complication rate and a 70% screen failure rate to begin with. And now these are all in expert centers. Now we're about to unleash this in the United States. So do you have concerns about that? And how would you undergo, should we say, the term that was used for TAVR, rational dispersion of this therapy?
So I agree completely with you, Mike. And as someone who proctors both devices, I am concerned. As you know very well, the balance between what is clinically judicious and what is commercially viable is difficult to achieve. We have conflicting priorities. And I think it's important that we don't rush into this therapy. And I think one of the questions that was raised was, did the FDA rush into approving these therapies? And I think it's a reasonable question to ask. For me, I think the big issue is, so one, yes, I think we need to be very judicious in terms of where these go, because it's not even just about expert operators. It's about expert imagers. It's about expert pre-planning. It's about expert management of these patients. A lot of them that we see in clinic, you realize, weren't appropriately tuned up before they were even sent. So I think to suddenly jump in and start putting devices in, we learnt this from COAPT on the mitral side. It's important to make sure first and foremost that we manage these patients, because the vast majority of these are functional. And so a lot of them do and will get better with medical therapy. We've just got to make sure we pick the right patients who truly have failed medical therapy. And I think the other issue is we need an annuloplasty solution, because we won't need to repair or replace the valve in the vast majority of these patients if we can find a suitable transcatheter annuloplasty solution. Now, easy for me to say. The engineers are obviously having a lot of difficulty to deliver us a device that does that. But I think we may have jumped ahead in terms of the right solution for these patients. But I share your concerns.
Thanks, Rahul. Great comments.
Can I ask something to Dr. Sharma? You hear me?
Of course, yes.
Yeah, absolutely. Go ahead.
Dr. Sharma, thanks for your presentation. We learned a lot from your presentation, very updated. We have very little experience compared to you, just 5 cases. But our experience is that the acceptance rate is much, much better, far better than the acceptance rate in the mitral TMVR trials. In the mitral TMVR trials we participated, the acceptance rate was like 10-20%. And here our experience says that the acceptance rate for our cases is probably 70%. And those rejections were just for size. So if the new size, the 56, comes through next year, then probably this acceptance rate will be even lower. So I'm a little surprised to hear that the rejection rate in the TRISCEND trial was 70%, like Dr. Mack said earlier. Can you?
So I think firstly, it's probably testament to the fact that you guys are appropriately submitting patients. There's obviously a degree of pre-screening that's going on, either consciously or subconsciously, where you're putting forward the right patient. So I would congratulate you on that. With respect to the study, I think we definitely saw a reduction, a drastic reduction from when we started the study to later in the study in terms of acceptance rates. And naturally, part of that is, and I was part of the screening committee for these, is understanding, we start off very cautious, appropriately so, and then as we get experience and we learn more about the device and more about the patient we're putting it in, particularly in complex and challenging anatomies, I think the judiciousness remained, but we were a bit more flexible in expanding what was included in the study. So we certainly saw the screen failure rates come down. And you're right, at the moment, the biggest screen fail reason is size or other anatomy that would preclude safe delivery of the device, mostly when it comes to flipping those anchors ventricularly. We're seeing fewer screen fails in late in the trough for patient-related comorbidities. They were screen failed out early, but patients who were too sick, too frail, or were deemed to have RV dysfunction that might preclude them became less and less common, I think, as people got familiar with what the right patient was. So certainly not as bad as the mitral TMVR space is right now.
Can I make one last question to Dr. Sharma, please? It's Dimitris Nikas from Ioannis University Hospital in Greece. I do understand the benefits and the advantages of the orthotopic replacement of the tricuspid valve. However, I do see that when these devices of heterotopic transcatheter tricuspid valve replacement came out, I said, oh, this is really clever. Do you see any future in these devices, or can you suggest, the reason, so two parameters that you probably choose one orthotopic device versus an heterotopic replacement of the tricuspid valve, or the opposite, vice versa?
I think that's a good question. I don't have any experience with the heterotopic devices. At the moment, I know there's been sort of very small volume, obviously, with the devices that are currently out there in that patient population. So I think that the greatest volume of experience we have is clearly in the edge-to-edge and now the replacement space. So I think there needs to be a little bit more data in the heterotopic space. It's mostly sort of small first in humans or very small EFS studies that are being done. But I think it's an interesting approach, but certainly one that there isn't enough data to merit any conclusions, and certainly not to make a decision on choosing.
For me as a surgeon, this heterotopic approach seems to me like more symptomatic treatment, and is more like bringing the problem a step before where it was. So I'm not sure it's a real treatment.
Yeah, certainly our early experience with putting stents or valves, albeit not designed for that purpose, in the inferior and superior vena cava was not successful. So again, now there's dedicated devices for this, but as I mentioned, I don't have personal experience with those devices.
Okay, thank you very much.
Thank you.
Should we proceed?